Hello, ladies and gentlemen. My name is Ty Basan. I'm a gastroenterologist working at Holyoke Hospital. And today the topic is going to be regarding colonoscopy and colon cancer screening. And hopefully we can increase awareness amongst the general population with this presentation. So, when you get referred for colonoscopy, sometimes people may feel a little bit, surprised by that because it's a very intimate type of exam. And in this cartoon here, as you can see, it's not because the doctor doesn't like you. It's actually because we care about our patients. We want to make sure that they get the best treatments that are out there and that can help their general health. And the reason we care about colon cancer screening is because colon cancer is one of the most commonest cancers in the US. It's just slightly behind prostate cancer in terms of new cases and deaths. So it's something that we can actually prevent. If we do a colonoscopy and we find those precancerous spots in the colon, we take them out, then we can significantly reduce the risk for cancer later in life. So it's actually a really worthwhile endeavor. Now, in terms of the colon itself, the colon is about 6 feet long, and as you can see in this diagram here, it's quite a twisted type of organ, and it goes all the way from your left side across the top of your stomach into the right side of your stomach. And we can examine this whole area, this whole segment very easily with the camera test, which we call the colonoscopy test. This graph that I'm showing you here just shows you that with time, increased improvement in treatments, and greater technology and awareness of colon cancer screening, we have increased survival rates from cancer, and deaths have gone down actually with time, which is great news. In terms of again, the importance of colon cancer screening, I want to share one case with you. It's a real life case. This was a patient, a sort of middle-aged lady that came of the right age to do colonoscopy, which was around about 50. And she was referred or advised to go for colonoscopy in 2012. And she had been actually referred before that as well. And as you can see here in the note, the doctor had written here, referred again in 2016. Again, the doctor had noted in their note that she was overdue on the colonoscopy, and she was advised the importance of colonoscopy for colon cancer prevention. Unfortunately for this lady, she indeed did have colon cancer, and you can see that here on the pictures. What you're seeing in the pictures is actually the cancer that she had. And the reason why I share this case is just to show you the importance of following through on those recommendations. And if your doctor thinks that it's time for you to have the test, then you should really give that due consideration. Hopefully that will save a life and save unintended consequences later. One of the commonest questions we get about colonoscopy from patients is about the bowel preparation. And I can only stress to the audience that the bowel preparation is a really important part of the colonoscopy. If you do a good prep and the bowel is clean and easily visualized, then we can really give you a good assessment, and we can make sure that you're cancer free. This is another case that I saw. As you can see on the slide there, on the 9 o'clock position, the patient came for colonoscopy, and there wasn't really anything that you could see because it was not well visualized. And the patient was educated on the importance of preparation and brought back again. And the same patient, in the top slide, 12 o'clock there, you can see a large mass lesion. Thankfully, that was not cancerous, and it was fully removed, which is great news for that patient. And hopefully we've saved that patient from developing cancer. The other important reason why we want to focus on bowel preparation is because it makes the procedure more prolonged. It can make it difficult to visualize things. It makes it harder for me as the operator to have a good evaluation of the whole colon. And obviously it means that patients have to come back again, maybe a couple of times before we can get a good view. So it's really important that we focus on a good bowel preparation. And that should be something that can be discussed with your primary doctor or with the gastroenterologist at the time of the colonoscopy when it's arranged. There are many different preparations available as well, and these can be discussed with your gastroenterologist or with your primary care doctor. Unfortunately, many times this will depend on what type of insurance you have as a patient and what the insurance will cover. There are some other regimens that can be used with over-the-counter medication, for example, using Miralax and a Gatorade preparation, which can be better tolerated from terms of taste and volume. But again, that's something you can discuss with your doctors. Here I'm just showing a slide, just demonstrating the Miralax preparation, which can be better tolerated and potentially less risk for dehydration as well. But again, like I said, worth discussing with your providers. And again, the reason why I'm mentioning this is to let the patients know that there's a wide variety of preparations that can be used, and not to be disappointed or dismayed if you're only recommending one thing. Now, some patients may say, okay, I want to be checked for colon cancer, but I just don't like the idea of having a colonoscopy. Is there another option for me? And there are other options, definitely. And again, something is better than nothing. So if you as a patient feel very uncomfortable having a colonoscopy, you think it's something very invasive, and you have issues about your intimate areas being revealed, then that's something you can certainly discuss with us in the office or with your primary care doctor. Other options right now, as you can see in the slide here, it's a little bit technical, I guess, but there are other options. Colonoscopy is recommended as the gold standard by the national societies. All the gastroenterology associations in America recommend colonoscopy as number one. But there are other options that we can do. For example, we can do an X-ray test, which we call barium enema. Again, you still have to drink a bowel preparation to clean the bowel out for that. But they put a tube in there into your rectum, and they put the dye, and then they can sort of visualize how the colon looks. There's also a special type of CAT scan, which would be done every 5 years. Again, you would drink a bowel preparation to clean out the bowel, and then they would do the CAT scan as normal, and they could actually see if there's any lesions or polyps or cancer in there. If you don't want to do any preparation, you feel uncomfortable with preparation, then there is some stool testing that can be done. We can check for microscopic blood in the stool, which can be a very first sign of colon cancer, or for large polyp lesions, and these would be done on an annual basis. There's another type of stool test which has been developed where they can actually measure genetic markers in the stool, and those will be done every 3 years. So all these things are available. Some people may be aware of a special type of capsule, which is a type of small camera which can be swallowed. A lot of places don't offer this right now. Certainly in Western Massachusetts, there's nobody offering that capsule test right now. And that's something that in the future may be available more readily. The only problem with that is it demands a large amount of fluid intake. If you don't like prep, then there's a lot more prep involved in drinking to clear out the bowel for that than it would be normally with a CAT scan or with a colonoscopy. In terms of screening, who do we screen? Up until just recently, we were recommending that everybody over the age of 50 until the age of 75 should be screened for colon cancer. That has actually been changed now to 45, and a lot of insurance companies are covering this new standard. And the reason why we're recommending screening from the age of 45 onwards rather than 50 is, although we're seeing lesser risk rates of colon cancer in older patients, we're actually seeing more colon cancer in younger patients, especially in the left side of the colon and the rectum. So because of that, the national societies have gone for 45 as a new age for colon cancer screening. Now, in terms of 75 and beyond, it's sort of a more individualized assessment at that point. My personal practice is, if somebody's over 75 and they're really healthy and they've got at least another 10 years of life hopefully in them, then I would recommend colonoscopy for further evaluation, or some type of screening if they didn't want to do colonoscopy. If they have significant health issues like cardiac problems, breathing issues, if they may not have a lifespan that may be 10 years or more, then maybe, it's not worth doing the colonoscopy. And that's something that, again, can be discussed with your provider, with your gastroenterologist, just to go over that in more detail. In terms of looking at some more of these modalities, again, these are readily available, such as the CT, colonography, or what we call a virtual CAT scan. Pretty much every hospital should be able to offer that. Again, that does require, as I mentioned before, a preparation. There's a tube that's inserted into the rectum, and so they can inflate the colon. It takes about 25 minutes on average to read the actual CAT scan, but only takes 10 minutes to actually do the actual test. So it's a little bit quicker than doing a colonoscopy. Obviously, there might be some radiation risk with a CAT scan as well. The radiation risk is pretty small. I don't think it's anything to worry about. But again, some people may, opt out of that because of that issue. And this is just a picture to show you what a three-dimensional CAT scan can look like in the left-hand side there. Picture A, that's actually a 3D CAT scan, and you can see it's showing you a polyp, that sort of swollen lesion right in the middle there. And you can see that on the same patient, the actual real-life colonoscopy, where they can actually see the polyp. And obviously, if you see something on the CAT scan, then you're going to need a colonoscopy as well to go in and take it out. So that's something to be mindful of. Instead of one test, you may end up having two tests. So just to be aware of that. This is showing a picture of what they can see when they do a capsule colonoscopy. The two pictures on the left-hand side there are the capsule, and you can see it's taking pictures in real lifetime of the polyp. And then in the same patient, you see on the right-hand side, you can actually see the polyp. And once again, these tests are good, but if you find something on them, then you're going to need a colonoscopy. So you need to be aware that if you do one of these other tests, if something is found, then you may need to eventually end up getting a colonoscopy. And this is actually a picture of what the capsule might look like that you have to swallow, and some of the other equipment that you would be wearing to catch those pictures. This is an example of one of the bowel preparation regimens you may need if you do a capsule preparation. You're talking about a lot of fluid, at least 1 gallon of fluid with senna tablets before taking the capsule, and then afterwards you're talking about another 6 ounces of suprep, which is another type of preparation, and you're talking about some other medications trying to accelerate the capsule through the bowel. One of the problems with the capsule as well is, again, you need a more extensive bowel preparation. Technical failure may be an issue. If you don't drink enough fluids or take enough preparation, then the picture quality may be poor. It may be hard to see what we call flat polyps, which are really flat, and they almost look the same as the normal lining of the colon. So it may not be seen that well in the capsule as opposed to a colonoscopy. In terms of stool tests, the good thing about the stool tests, you don't have to do a special diet. You don't have to take any bowel preparation. It can have a good level of accuracy in picking up colon cancer, 80% sensitivity. It's pretty cheap as well. It's not that expensive. The only problem is it's something you'd be doing every year. Another issue with it as well, it might miss low-level polyps that have not quite reached an advanced level. Whereas with colonoscopy, you can actually detect polyps at a very early stage before they become advanced or cancerous and take them out. The next test that I did mention earlier was this genetic test. It's a DNA testing where they can measure markers of colon cancer in the stool, and they actually combine this test with looking for microscopic blood. It does have a very good rate of pickup for colon cancer, 90% according to studies. It can be also a good test for picking up large polyps that are over centimeters, so about 40% of polyps like that can be picked up. And it will be covered by insurance, usually for every 3 years. Again, caveats for these tests, if they come back positive, then you're looking at at colonoscopy, possibly to look inside there. And you can have false positives as well, which means that, you know, it may come back positive, but you actually don't have anything inside there, and that's not an uncommon scenario that I've seen. There are some blood tests. They're not ready for prime time, and I would not recommend doing these blood tests. If you see these, you know, by private labs, there's not something that I would recommend because it's not approved. It's not been shown that these have great sensitivity or ability to pick up cancer at this point. In the future, maybe, but not right now. Some people, you know, may ask, you know, who should get screening for cancer. I already mentioned that we recommend everybody from 45, which is the new age, which used to be 50, should get screened for cancer. But if there is a family history of cancer, if, you know, somebody close to you, what we call a first degree relative, so that would be mother, father, brother, sister, if one of those individuals has cancer or they have large polyps, then, you know, your risk of having cancer or polyps may be 2 or 3 times more than somebody who doesn't have that family history. So in those patients, we may do colonoscopy earlier at the age of 40 or 10 years before the first diagnosis of cancer or large polyp lesion was made. If you have first degree relatives, more than 1 or 2, then your risk goes proportionately higher. And again, on an individual basis, we may decide to do colonoscopy at an earlier time or do some type of screening before, you know, 45. There are certain diseases where you have a high risk for cancer as well. Crohn's colitis or ulcerative colitis, which are types of inflammation in the gut. Those patients may have a high risk for cancer, so we may do colon cancer screening in those on a yearly basis. Also, some people may have genetic diseases, which means they have to get colonoscopies every 1 or 2 years. Again, this can be discussed with your primary doctor or with your gastroenterologist to decide, you know, what type of screening time frame you may need as an individual or as a family even. Again, this table here that I'm showing you just shows you, you know, recommendations for when patients should be screened. Again, as I mentioned, this is a bit outdated. The new age now is 45. But if there's a family history, then age 40 years or 10 years before the youngest case in the family, whichever is earliest. And those genetic syndromes, again, can be individualized and discussed with your doctor. Some people may ask, you know, is there something I can do to prevent cancer? And yes, there is. There are things that can be done. We do know that there are, as I'm showing you on the slide here, there are several risk factors in terms of your, you know, daily life. One of the biggest things can be diet. We know that a diet high in red meats and processed foods, you know, beef, pork, lamb, liver, can increase your risk for colon cancer. Foods that are fried, broiled, grilled at very high temperatures and charred, they can increase your risk for colon cancer. General things that are, you know, being overweight, smoking, heavy alcohol use, lack of exercise, all these factors can increase your risk for colon cancer. And as a general rule, what I tell patients is whatever's good for your heart is good for your gut. So, you know, a heart-friendly diet is definitely going to be gut-friendly. So, you know, if you cut out smoking, you reduce your alcohol intake, more physical activity, at least 30 minutes of physical activity, you know, 4 or 5 times a week can definitely reduce your risk for cancer. In terms of, you know, general advice, again, as you can see in the slide here, how to reduce risk for colon cancer. This is from the American Cancer Society Colorectal Cancer Facts and Figures guidelines. And as they've mentioned here, you know, number 1, get your screening regularly, have a healthy weight throughout your life, physically, you know, be active, healthy diet, you know, limit consumption of red meat, processed meats, at least 2.5 cups of vegetables, fruits each day, whole grains instead of refined grain products. Limit alcohol consumption, more calcium, vitamin D in your diet, and avoid tobacco. I did sort of allude to this earlier, and again, I just want to go back to this point that, you know, because of cancer screening, you know, guideline changes, where we change from 50 to 45, The reason for that was we did see increased rates for cancer in younger patients. And this in this slide here, there's a lot of information and data in this slide, and I don't want to dwell on it too much. But basically, what all these graphs are showing is that, you know, cancer rates in younger population is going up, especially in the 35 to 49-year-old group, and even actually in the 20 to 34-year-old groups. But in the other older groups, where we had been doing screening very actively, the cancer rates are going down in colon cancer. Some people may ask about aspirin use. Aspirin has been associated with reduced risk for colon cancer because it reduces some of the inflammatory markers in the gut. We are not recommending that people take aspirin unless they need it for other issues, like for cardiac issues. Reason being that aspirin can cause a risk for ulcers and gastric problems, but it is something that you might want to discuss with your primary care doctor if there is a high risk for, you know, cardiac issues in the family, or a person has cardiac problems. Then maybe aspirin may be a good thing for them to be on. If there are questions, then, you know, again, your primary care doctor is a good resource, and if they can't answer those questions, then, you know, the gastroenterologist should be able to answer all those questions. Those providers should be able to address your concerns that you may have regarding cancer screening, questions about cancer risk, questions about how to prepare for colonoscopy. So all of these things should be addressed by your gastroenterologist. So thank you for listening to my talk, my presentation, and hopefully this will encourage more of you to consider, you know, the importance of having colonoscopy screening for cancer prevention.